Now let's open a major case file, HIV and AIDS. This isn't just a virus, it's a master of disguise. We are going to track it from the moment it enters the body to the final diagnosis. We are covering competency PA 9.6, viral structure, pathogenesis, and the NACO testing strategies. Put your gloves on, let's examine the suspect. First, we need a description. Here's the enemy profile. We are looking for a retrovirus with a very specific toolkit. Look at the surface proteins. GP120. This is the key. It picks the lock on your immune cells. GP41. This is the crowbar. It pries the cell open for entry. P24. This is the core. We call this the capsid antigen. Remember P24. This is the target we look for in early screening with 4th generation ELISA. It's the fingerprint left at the scene. How does the crime go down? We call this the hijack. It happens in 3 steps. In step 1, the GP120 binds to the CD4 plus T cell. The virus handcuffs the general. Step 2, it needs an accomplice. It binds to a co-receptor CCR5 or CXCR4. Step 3, GP41, the crowbar, pierces the membrane causing fusion. Once inside, it uses reverse transcriptase to rewrite the code. The cell is now a factory for the enemy. Every crime has a timeline. Watch the CD4 count, the blue line, crash while the viral load, the red line, spikes. Acute phase. There is massive viral spike, the patient feels like they have the flu. Clinical latency. The suspect goes underground. The virus is replicating quietly in the lymph nodes. AIDS phase. The defense collapses, CD4 count drops below 200, and now the opportunistic infections move in. Now let's see AIDS defining opportunistic infections. Respiratory. Pneumocystis girovecii pneumonia. It gives ground glass appearance on X-ray. Tuberculosis, often extrapulmonary. In CNS, we see toxoplasmosis, the ring-enhancing lesions, and cryptococcal meningitis. In GI, we see esophageal candidiasis, cryptosporidium, causing chronic diarrhea. Malignancies. Kaposi sarcoma. It is caused by HHV8. It is a vascular tumor and is seen as red or purple patches on skin. Invasive cervical cancer. It is HPV driven. Non-Hodgkin's lymphoma, EBV driven. How do we catch them? We follow the NACO guidelines. We have 3 different strategies depending on why we are testing. You don't just run a test, you run a strategy. Strategy 1 is for blood safety. Strategy 2 is for surveillance. Strategy 3 is for diagnosis of a symptomatic patient. First, understand the 3 kits A1, A2 and A3. SA1 or A1 must have high sensitivity. We don't want to miss anyone. Usually a 4th generation ELISA detects P24 antigen and antibodies. SA2 or A2 and SA3 or A3 must have high specificity. We don't want false alarms. These must use different antigens or different principles from A1. Strategy 1 is for blood banks. The goal here is maximum sensitivity. We cannot afford to miss a single drop of infected blood. The protocol here is that we run one test A1. If it is negative, the bag is safe. If it is positive, discard the bag. We don't confirm it, we just throw it out. We don't diagnose the bag, we protect the supply. Strategy 2 is for surveillance. This is for counting numbers, not treating patients. The protocol here is we use 2 tests, A1 and A2. Test A1 is positive, then run test A2. If both are positive, we count it as a case for our statistics. We do not give this result to the patient yet. This is for the health ministry's big board. Now for the real work, strategy 3. This is for diagnosis. The protocol is you need 3 distinct tests, A1, A2 and A3. They must use different antigens or principles. If A1 is positive, go to A2. If A2 is positive, go to A3. Only if all 3 are positive, you hand down the verdict, HIV positive. What if A1 is positive but A2 is negative? That is a discordant or indeterminate result. Send the sample to NRL, National Reference Laboratory, for Western blot or PCR for viral load. Do not tell the patient they have HIV yet. Repeat testing may be required after 2 to 4 weeks, which is the window period. We have a special case file, pediatric diagnosis, that is, for diagnosis of children less than 18 months. The problem here is the baby has the mother's IgG antibodies. If you use ELISA, it will come back positive even if the baby is not infected. That is a false positive. Solution here is do not look for the antibody, look for the suspect directly. We use DNA PCR on a dried blood spot. Never use ELISA for a newborn. Once we have a verdict, we launch the counterattack. The policy is test and treat. We don't wait for the CD4 count to drop anymore. We start ART immediately. Our goal is the UN AIDS 95-95-95 targets. It states that 95% of HIV positive people should know their status, and 95% of those diagnosed are on ART, and 95% of those on ART have viral suppression. Let's close the file with the cheat sheet. Snapshot this. Screening test is 4th generation ELISA. It detects antigen and antibody. Confirmation is done with a Western blot or PCR. Strategy 1 contains 1 test and it is for blood safety. Strategy 2 contains 2 tests and it is for surveillance. Strategy 3 contains 3 tests and it is for diagnosis. Case closed. You know the enemy, you know the timeline, and you know the protocol. Let's recap the high yield points. Look at the comparison. In innate immunity, it is fast, non-specific, and has no memory. Adaptive immunity, it is slow, specific, and has memory. Innate buys time, adaptive wins the war. Now the HLA math. Never get this wrong again. The rule of 8. MHC class 1 found on all nucleated cells. It presents to CD8. 1 multiplied by 8 equals to 8. MHC class 2 found on APCs. It presents to CD4. 2 by 4 equals 8. If the math adds up to 8, you have the right answer. Open your arsenal. You need these mnemonics. Hypersensitivity is acid. Type 1 anaphylactic, type 2 cytotoxic, type 3 immune complex, type 4 delayed. The lupus code for SLA is SOAP brain MD. Serositis, oral ulcers, arthritis, photosensitivity, blood, renal, ANA, immunologic, neurologic, malar rash, discoid rash. Well, that was a marathon, but we have built the foundation of immunology. If you have any doubts, drop them in the comments below. Don't forget to like, share and subscribe to Conquer Pathology with Dr. P. Keep studying, stay curious, and I'll see you in the next lecture. I've created a high-yield PDF cheat sheet of all these tables and flowcharts. The link is in the description. Good luck studying.